To introduce our next speaker, Dr. Laith Al Rubaiy, consulting gastroenterologist at St. Mark's, who is going to talk to us about damping the flame of inequality.
Thank you very much, and good afternoon, everyone. You've seen from the great talks that we had earlier that the therapeutic landscape and the research in IBD has never been stronger, yet the benefit to our patients not felt globally. A child with Crohn's disease in rural Asia more likely to have a frequent steroid courses and being steroid dependent than a child with Crohn's in London. And many patients still in the rural countries, they still first present with their IBD at the time of surgery. And we have great talk about the biomarkers and how to predict the personalized care. But globally, the best predictor for an outcome of patients with inflammatory bowel disease is actually the healthcare system and the country where they are because of the infrastructure. And I am a gastroenterologist. I worked in St. Mark's and I also worked and lived in different parts of the world. And what I will try to do today is to take you through the epidemiology of IBD globally, and I'll show you how the shift in the epidemiology of IBD will also try to give you a gradient of how inequality is across the world. And then finally, we'll talk about a few strategies, which is evidence-based, how to address this inequality. So we all know IBD is a global condition. However, the gap between the rich and poor is getting wider. And in many low middle income countries, the incidence and prevalence of IBD is rapidly accelerating. And because of that, the health care system is not very well equipped with the sudden rise of IBD, leading to inequality and worse outcomes as mentioned previously. And we know that's about 7 million patients with IBD across the world, with high prevalence in North America. But we also know that the year lives with disability, which is the YLD, has doubled in the last 3 decades. Means patients are living longer. We are getting better in survival, but also reflect the chronic impact of IBD on their quality of life. And while we've seen a plateauing in the IBD in Western countries, there is a rapid acceleration of IBD in newly industrialized regions in the world. This is partly because of the factors mentioned early, which is the urbanization, the Western diet, and the microbiome shift because of frequent antibiotics on the environmental factors. However, the diagnostic and the therapeutic capacity of these regions is still very limited and is lagging behind this acceleration, leading to a huge difference in the quality of care. The 4 phases of epidemiology in IBD is the strongest framework to describe how IBD is evolving. While we can see that many of the low middle income countries are firmly in the acceleration phase, the high income countries in the compounding stage. It's very important to realize what stage the IBD is, because you want to plan your health service around that stage to cope with the increasing number of cases. We know from the data that actually the clinical care of IBD contribute to 20% of the outcome of IBD. Majority of the factors that affect the clinical outcomes are to do with the socioeconomic factors, such as economy, education, community, healthcare, and environments. Therefore, ignoring the social determinant of health means you're missing the root cause of the problem. We can offer the best clinical care, but without addressing these factors, there is still gap in the care we provide. We know from the data that we have in Manitoba, for example, that the low social economic status is associated with worse outcomes. Globally, there is food insecurity, there is financial toxicity, and will lead the patient to skip doses, not come to their appointments, and they often have to choose between providing food to their family or paying for their treatment. And that's why there is inequality of care. There's a huge gap in the infrastructure worldwide, especially in the developing countries. There's shortage of IBD centers, lack of well-established MDT like we have here in the UK. There's limited access to endoscopy and pathology, and there's a very, very fragmented referral pathways from the primary care to the secondary care. And when we talk about inequality, there are four main categories for inequality. We have the availability of drugs and the availability of the specialist IBD doctors. But also, even if the drugs are available, the affordability is still an issue. Within the same country, you can see some people unable to afford treatment because of their insurance category. And then the lack of national or regional guidelines lead to inconsistent quality of care in different parts of the world. And this collectively will change the outcomes of patients with IBD. There's a huge delay in diagnosis of IBD, and this is one of the major issues. We mentioned earlier that many patients still present for the first time with their IBD in the theater, having surgery for their stricturing disease or perforating IBD. There's a long waiting list. Their diagnostic capacity is not coping with the number of cases, or there's a delay in referral to the tertiary centers with the delay the initiation treatment. And we know from the evidence that early treatment leads to better outcome to prevent the mucosal damage. And we know from the data, this is Rupa, one of the good colleagues who works in India, published widely about the IBD care in the Asian countries. We know the utilization of biologics is very low in Asian and middle income countries compared to Western countries. And this is mainly because of the financial pressure and the out-of-pocket money. And this will lead that many patients are still on steroids and requiring frequent courses of steroids. We know IBD is a very, very expensive disease. It's a huge burden on economy. And most of the cost of IBD comes from the biologics treatment. They contribute to around 60 to 80% of the cost of the IBD. But also for the same drug, you can see a wide variation of the cost of the drug in different countries in the same region. Apart from the financial cost of the IBD, also we have indirect costs related to the loss of productivity and disability associated with disease. And because of the cost of the treatment and the financial burden on patients, patients often choose between survival or having their treatment. And obviously, they choose the family first in most of the scenarios. When it comes to surgery, surgery is still commonly used in underdeveloped countries where patients present for the first time with complicated IBD illness. And this is mainly because of the delayed diagnosis or suboptimal therapy. We know this is preventable because the data tells us that with optimal medical treatment, you can reduce the need for surgery by 40 to 60%. When it comes to mental health, it's a huge gap in the developing countries. We know from the evidence that depression and anxiety affect about 1/3–1/4 of patients with IBD, yet less than 10% of patients with IBD having access or being seen by a specialist psychology. Young people and adolescents where the IBD tend to peak, their IBD care is very fragmented. There's lack of access to specialists, pediatric IBDologists. The referral takes ages, and this is why most of the patients get diagnosed later and ended with the steroids at childhood. In the Middle East, where I am from, it's a dual reality. So we have places where you have state-of-the-art centers. You have cutting-edge technology, but you also have countries with limited resources. And because of the insurance category, you can see intra-national variation in the affordability and accessibility to biologics. And this will lead to a divide between different places, commonly good care focus in major cities and capitals, while rural countries lack their infrastructure. This is a recent systematic review that we did when we looked at the studies and the real-world data of advanced medical therapies in the Middle East. You can see there's a growing adoption of advanced medical therapy in the Middle East, especially in the rich Gulf states. And the outcome, actually, if they get adopted, you can see the outcome is very much similar to the outcomes we have from Western countries, which tells us that this issue is accessibility rather than the biology itself. However, when we looked at the data and the literature from the region, We examined 59 studies from the Middle East. However, there were only 2 countries who dominated the literature, mainly Saudi Arabia and Israel, which tells you that there's a huge gap in the data that we have in the field when it comes to IBD. Obviously, the lack of the local and regional data will affect your planning and we will not be able to plan the service around the local regional need. And this is a paper from Shihab, my friend from Kuwait, and we showed that the efficacy of biologics and small molecules is very much similar to the Western countries in IBD. Again, if you just proving the point that equal access leads to equal outcomes. Apart from the financial barriers that we mentioned earlier, there are other barriers that we struggle in the Middle East and in developing countries. The limited centers and fragmented referral pathways. We have the cultural stigma and the dietary myths. Herbal remedies are still there. The lack of consistency in regional and national guidelines, and the weak pediatric to adult transition, leading to many patients getting lost in the pathways. All these affect the care of IBD in the region. And biosimilars has changed the way that we address IBD in the developing countries. They're one of the strongest elements or tools that we have to reduce the cost of biologics in IBD. However, the uptake is uneven across the regions. There's still lack of trust between the policymakers and physicians when it comes to biosimilar. And therefore, switching patients from the originator to biosimilars requires a huge deal of education and communication to allow this to happen, to end up saving money. And when we look at the data, the evidence we have in IBD is very much skewed to Western population. We don't have national or regional IBD registries, and most of the countries in developing countries are missing from the randomized controlled trials just because you don't have the infrastructure. And this obviously will leave a gap in the data when you apply what you've known in the literature in this part of the world. What isn't measured cannot be managed, and this is what I wanted to take home from that. We'll spend some time on the strategies. I've got 2 minutes and hopefully finish on time. But we want to expand more on the biosimilars. Biosimilars getting cheaper. We have now 3 biosimilars for ustekinumab. We have well-established anti-TNF biosimilars. Hopefully more will come and will cut the cost in the future. There are talks about universal health coverage, especially for chronic illnesses, including IBD, to avoid this intra-national variation when it comes to coverage of IBD. There's a big lobbying and government negotiation with the pharma company to get the bulk procurement and get the cost of biologics or advanced medical therapy to affordable level. And we need to include population from low-income countries in the clinical trials to really look whether they do well with the new technologies and the medicines that we've seen earlier. And global partnership is much needed. We are in discussion to develop St. Mark's IBD fellowship with the Middle East. Hopefully this will ignite further collaboration in the future. And the focus of the global collaboration will be more about education, training, and sharing knowledge and expertise. And my aim is to have the same standard of IBD care regardless where you are in the world. Ideally, we should have the care tailored for patients' needs rather than tailored by the income of that country. And this will lead to a better outcome of our patients and saving money in the long term. I will finish with this slide. I've got 30 seconds to finish, but unfortunately. So all I want to say, I'll leave you with 3 messages. That first, IBD burden is global. However, the care is unequal in different parts of the world. And I wanted to pay attention to the social and financial barriers because this is what's impacting the outcomes globally. And we need to work together to allow equitable access to therapies, to allow equal care for patients across the world. And by this, I will finish on the dot. Thank you.
So great talk, Laith, and great questions from the online audience as well. Are there any questions from our live audience? I would like to ask you, if you had to choose one or two things to improve the global equity to IBD treatment, what would you do?
That's a very, very good question, because we have to acknowledge the limitations that we have in this part of the world, mainly financial. But I think if there's one thing I would encourage is early screening and referrals. Calprotectin, for example, is not used widely in the setting. And if we can make it a common practice to screen patients, at least with the fecal calprotectin, to pick up those patients early and refer them to wherever center is available, this will give them the chance to be picked up early, start treatment early to prevent the long-term disability and complication. So screening and early referral is one thing I would definitely invest in.
I think that's the key point, really. It's the R of reach. It's the rapid, isn't it? Rapid diagnosis and treatment is such a core global goal. But out of the rapidity of diagnosing, do you think it is the patient? Do you think it's education at the patient level, or the primary care level, or the secondary care? Where do you think the biggest block is from where you've been working? Just your impression of it.
So I think historically was more physicians, but now with opening resources, everyone's attending conferences. I think physicians are getting better and better in being more aware of IBD and treatment. We're still lagging in patients' education. We don't have charities like here, for example, Crohn's and colitis UK. We don't have sort of IBD well-established patient charities. And I think this is the area that we need to work on in this part of the world, just to raise awareness of the condition, remove the stigma of having IBD. It is a condition that we can manage, but it's not end of the world. And this is why I'm trying to spread the message in that part of the world.
Okay, any more questions from the audience? Otherwise, I'd like to thank very much you, Laith. Fantastic talk.